Good afternoon, everyone. This is Rajdeep here. I work as a nuclear medicine technologist here at the Royal Free London NHS Foundation Trust. Today, I will be talking about transplant renogram acquisition and processing. We'll be covering clinical indications, imaging parameters, processing, interpretation, as well as few examples to show how we are doing it over here. To begin with, nuclear medicine has a significant role to play in the management of renal transplant recipients in the post-operative period. Scintigraphy is performed shortly after surgery for baseline function analysis with follow-up renal scintigraphy imaging if there is any concern regarding the transplant, for example, deterioration of function or post-surgical complication. Here are the main clinical indications for transplant renograms. They are to evaluate arterial flow and function rejection, acute tubular necrosis, urinary leak, renal artery stenosis, infarct, or obstructions. Before starting the acquisition parameters for the patient preparations, there are no as such patient preparations for the study apart from hydration. The patient should be well hydrated prior to the procedure, since suboptimal hydration may produce a scan result that mimics allograft dysfunction or obstructions. The IV lines should be placed beforehand if in case it's an inpatient where they already have the IV cannula fitted in. It's better to check it if it is working properly by flushing at least 10 ml of saline. Once it is all set, the patient is positioned over the bed. A large field of view camera with low energy all-purpose collimator is placed over the anterior abdomen in such a way that the abdominal aorta, the graft, and both iliac arteries are included in the field of view. Since it's a true dynamic study, the protocol should be set up for acquisition so you can start straight away after the injection. In the acquisition parameters, the matrix size normally we use is 128 by 128, zoom 1.45. The first phase, which is the 1 second per frame for initial 60 seconds. The second phase, that is the tubular phase, we use 20 seconds per frame for remainder of the 20-minute studies. After the initial acquisition, pre and post micturition images are acquired for 1 minute each, which can be acquired while standing or lying down the bed, depending upon the patient mobility. If patient has catheter bag, it's better to lower down the volume before starting the procedure as well as in the end of the study. Also, in those cases where the patient has a catheter bag, separate image of the bag is also acquired. SPECT CTs are routinely performed to investigate urinary leak, to define location of the leak with the transplant kidney and adjacent structures. In case of autograft kidney, where in some cases the patient has issue with their own native kidney, one of the native kidney, they might be placed anteriorly, and in those cases we will be acquiring data with both the detectors. So both detectors should be used. Let's have a look at the time activity curve just to give a basic idea. The time activity curve over here is without the background subtraction. Normally the time activity curves are generated from regions of interest that include the whole kidney and the iliac artery. In technetium 99M MAC3 study, because of high tracer extraction, the activity in the graph steadily increases and the background decreases. As you can see in the graph, the first phase, which is the vascular phase, which is the evaluation of the blood flow. So this facilitates renal blood flow to blood flow in the aorta or iliac artery. During the perfusion phase, the transplanted kidney normally becomes the hottest structure within 2 to 4 seconds of activity appearing in the adjacent iliac artery after a good bolus of radiopharmaceutical. However, achieving good perfusion images is extremely difficult, especially because most patients with renal transplants have limited vascular access as a result of prior dialysis. The second phase, which is the tubular phase, in the second phase, the nephrons extract the radiotracer from the blood to be excreted into urine by either glomerular filtration or the tubular excretion, which is normally 20 to 30 minutes after the injection. Time activity curves are sometimes generated from subregions of the kidney, such as the cortex. It can be approximated by whole kidney transit time or simply by the peak time, maybe delayed in patients with renovascular insufficiency, renal failure, or obstructions. The third phase, which is the drainage phase, corresponds to the drainage of the palicalcular system. And data acquisition for the drainage phase is normally the same as for the tubular phase. The data analysis, the images are normally displayed in the same format and in continuity with those from the tubular phase. Retained activity, whether in the pelvis or the renal parenchyma, is readily identified from the images. The distinction between cortical and pelvic retention is important, with parenchymal retention being the hallmark of acute tubular necrosis or acute rejection, and pelvic retention being the hallmark of obstruction. If parenchymal or pelvic retention is severe, there may be no peak, the curve rising continuously throughout this study. Let's talk about the image processing. For processing, it is important to select the correct data. So in case of transplant renogram, we will be selecting anterior detector, pre-mixed and the post-mixed series. First, review the images for the movement. If there is any movement, motion correction can be done to align the images. There are mainly the three ROIs we are drawing here. The one is the iliac artery, then transplant kidney, the perfusion part. As the main blood supply to the transplant kidney is by the closest artery, which is iliac artery, so the blood ROI can be drawn over the common iliac artery or the femoral iliac artery. So try to keep the ROI within the vessel wall. Care should be taken to not to overlap the transplant kidney and the bladders, as it can affect the blood curve. If a bolus injection was achieved, there should be a small peak in the blood curve on the perfusion graph. And the iliac artery will depend if the transplant was done on the left side, so that we will be drawing the blood ROI on the left iliac artery. If it is on the right, then on the right iliac artery. Then we'll be drawing the ROI over the transplant kidney. And care should be taken again to that it's not too tight or too loose. The transplant kidney ROI, it should be optimal. And also here in RFH, we do draw separate perfusion ROI just for the visual analysis. In that case, we always try to exclude the iliac artery, as you can see as it's shown in the image on the left upper corner. A normal renogram curve demonstrates a rapid upslope, which reflects the initial arrival of the radiotracer in the kidney, followed by the cortical concentration phase, which contains the peak of the curve. Cortical retention is seen in acute rejection or acute tubular necrosis. Interpretation: in the normal transplant, peak activity is reached by 5 minutes, and the activity will decrease to half the peak activity in another 5 to 6 minutes. With technetium 99M Mag3 or iodine 131 or iodine 123 iodohyperate, most of the tracer will be in the bladder by 13 minutes with little background activity. In severe cases, no activity is excreted into the bladder, a finding seen less commonly with acute rejection. So here we'll be having few examples to show different results. So this was the day 2 post-renal transplant, query for transplant kidney architecture and perfusion. The processing is done by using Hermes software here at Royal Free Hospital. The first graph represents the time activity curve. There is not much drainage from the transplant kidney as we can see on the images, so the curve is not descending. The second graph represents the outflow from the kidney, whereas the third one is the blood and the perfusion curve. As you can see that there is a spike in the blood curve which represents the good bolus injection if you look at the graph on the left lower corner. So finding in this case was the right iliac fossa transplant kidney appears well perfused, no focal peripheral cortical defects to suggest the infarct. There is uniform selective tracer uptake but impaired tubular secretion with a slowly rising time activity curve. No evidence of excretion into the collecting system. Appearances are in keeping with acute tubular necrosis. In next example, we have day 5 post-renal transplant. Query to assess transplant kidney function, query for rejection. The transplant kidney is visualized in the right iliac fossa. The lower half of the transplant kidney, as you can see, is overlapping the distended urinary bladder. So the region of interest for time activity curve cannot be drawn properly due to overlapping. The transplant kidney shows good perfusion and cortical uptake with prompt excretion and early spontaneous drainage. There is some tracer retention noted in the transplant kidney on post-micturition images. However, no significant holdup of tracer activity is seen in the pellicalcular system of transplanted kidney. So the next one we have is the day 4 post-transplant delayed graft function. In this case, the patient had a difficulty cannulating, so the injection was given on the left leg, and as you can see the transplant kidney is also placed in the left side. So the blood ROI was drawn initially on the left iliac artery. As you can see on the perfusion graph, the blood curve it's descending instead of ascending, which should be other way around. So in cases like this, the blood ROI has to be in the opposite side. In the next slide, the ROI was drawn on the opposite side and you will be able to see the difference between them. So as you can see on this image, the ROI was drawn on the right iliac artery, and then we can see the difference in the curve pattern. So in the cases like this where you have no option of cannulating then in the leg but on the same side of the transplant kidney, so it's better to go for the blood ROI on the opposite side. The findings in these cases were reasonable. There was a good perfusion to the left iliac fossa renal transplant. There was progressive accumulation of activity in keeping with severe acute tubular necrosis. No evidence for tracer excretion or urine production. The next one, we have just a simple example to show how we include the catheter bag in the post-make views. And as you can see, in the pre-make we acquired just normal like we do in the patients where there is no catheter bag, but in the post-make the urine bag was placed in the field of view. So this was the day 1 post-operative renal transplant query for the perfusion of the transplant kidney. The findings were the satisfactory perfusion of the right iliac fossa transplanted kidney with normal tubular function and the drainage. So next one, we have a case of urinary leak. The patient had a history of cadaveric renal transplant 10 days ago. So the query was to look for urine leak from the transplant ureter. After initial imaging, delayed images were required for every 1 hour up to 3 hours, and then the SPECT-CT was performed. In the findings, there is a progressive accumulation of tracer within the parenchyma of the right iliac fossa transplant in keeping with acute tubular necrosis. There is urinary lake with tracer visualized within the collection around the ureteric stent as it passes through the pelvis from the transplant kidney to the bladder. There are some pitfalls, like if the small IV set was used, or the injection was not a good bolus one, or if the dose was extravasated. These can lead to mimic decreased blood flow to the transplant. And if the injection was given in the central line, so it is better to start the acquisition bit earlier, otherwise you will miss the perfusion phase cause of the injection arriving rapidly in the kidney, which might lead to non-diagnostic. And the collimator, which has to be low energy all purpose, and the detector, which is imported rather than in normal renogram we use the posterior detector. Here will be using the anterior detector as the transplant kidneys are placed in the placed interiorly. The windowing, mostly the for the pre-mixed, post-mixed images and the initial flow, they have to be at the same range. Thank you.